Hey folks, my guest today is Adi Berenson. He's the co-founder and CEO of Claire Labs. Prior, he was 3 years as human interaction designer and prototyping at Apple. And before that, 8 years as VP of business development and marketing for Prime Sense, the leader in 3D sensing technology behind Microsoft Connect and Apple's Face ID cameras. Prime Sense was acquired by Apple. Adi, are you ready to take us to the top?
Yeah, thanks a lot.
Okay,
Great to be here.
you
Yeah,
bet. So Claire Labs, that's CLAIR. You're building contact-free remote patient monitoring systems.
mhm,
What got you into that
yeah.
space?
So actually, it's all started from our work in Apple, which I cannot get too much into it. So my background is coming from consumer electronics, but in my days in Apple, I got to work a bit with them on digital health projects. That was back in 2017. And I realized what a monumental challenge it is for modern societies. And once I started getting into this and learning about how old-fashioned workflows are there, we realized that technology can make a huge difference. I mean, we very, very quickly, even before we started the company, we narrowed in on an horizontal workflow, which is patient monitoring. And I can get into it more, but I'll follow your
Okay.
lead. Yeah.
So patient monitoring, there's sensors that are installed. So is there an IoT play here? Do you pay for the sensor installation?
So it is an IoT play. You got it right. The unique part about it is that it is not touching the patient. So clinicians are calling it passive monitoring because the patient doesn't need to do anything. So contact-free is not wireless. It's actually collecting the signals environmentally without touching your skin. It's not a
Oh,
B2C
Adi, what
play.
is it though? Is it like a lamp you sort of set next to your bed? Like, how do you think about it?
Yeah, it's a beautiful comparison. It is like a lamp. Yeah. So it does need to have some kind of line of sight to your skin. Okay. And then by looking at your skin in two waves of near infrared, it can see movements of superficial arteries. So arteries that are very close to the surface. By looking at those arteries, we see volumetric changes and we see tone changes. And then we are actually recreating or regenerating the pleth signal, pulse rate, oxygen sat, respiration rate, and so on.
Interesting. What does the physical device cost?
Okay, so I'm not gonna, I mean, forgive me for that, I'm not gonna expose our cost because we're not selling it to the consumer. The way it works, the business model is that our customers are providers, are healthcare providers, and they're offering it under, I will call an umbrella of RPM, remote patient monitoring services, which is reimbursed by Medicare and all major healthcare payers.
Mhm.
So it is a prescription service. The device is FDA cleared. And the way it works is the payer is paying for it as long as you are recognized as a chronic patient or a patient at some kind of,
Are you
hospital at home.
manufacturing it directly? Did you have to go source in China the manufacturing plant, or is this
Yes,
someone else's
yes.
technology, like
No, 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 no,
hardware?
no. No, no, no. It's our hardware. So it's our own hardware. We are sourcing it exactly as you mentioned. We're fabless, of course. So we're sourcing it in China and we are building the device itself. Yes.
When did you ship your first device?
So we are currently actually in clinical trials. So the devices that we are shipping into facilities in the US for clinical trials are actually not built in China. They're built in Israel in a low volume prototyping facility. The trials are going on for 2 months already. And so it's not in production
How
yet.
many have you produced for all the trials combined?
50,
Five
give
zero.
or take.
Okay.
Yeah, 50. That's it. It's very low volume. Yeah.
Okay,
Yeah.
50 for testing. Got it. And the healthcare providers are obviously the customers. Tell me about how you make money from them. What do they pay you on average per month?
So I'm not going to get into numbers, but I'm going to get into the business model. So basically, the components that the payer is paying the healthcare provider is made out of installation, is made out of what the clinician is getting to review the material, and is made out of the actual monthly payment for digitally collecting the signals from the patient. I'm getting most of this. And now I'm going to explain a little bit. So I'm not going to get into my revenues, but the way it works is that if you have a
Well, I
chronic
mean, just to
patient,
be fair, you're like, I mean, you're basically pre-revenue. You're doing clinical trials, right?
absolutely, we're pre-revenue, but we do have a plan. So I can give you an
Well, yeah. I mean,
idea.
so when you say you don't want to get into your revenues, I mean, you can just tell me you're pre-revenue, right? That's a much better way to say it. Makes it very easy.
No, but I thought you were referring to what are our plans regarding revenue. So today is zero. Yeah, fair enough. Yeah. But if you want to know how big is the market and what is our plan for future revenues, and I can give you one data. A chronic patient recognized as such under an RPM program can generate revenues for the care provider in the order of magnitude of $150 per month. It makes out of several components. So this is $1,800 per year. We believe that we're going to get a big chunk of it. That's the business model. So we're not charging the provider for the device itself. We're actually getting recurrent revenues out of the reimbursements.
So let's just focus on Israel for a second. How many patients do you believe should have this lamp next to their bed, right? That should be sort of paid for with, the government money, right? Medicare, Medicaid, whatever you guys have in Israel for that.
So I will actually answer you in US numbers, because that's the market that we analyze, and that's the market we're targeting. So the way it works is that I can picture for you right now a dream of all the chronic patients, but that's going to be a little bit superficial. So there is, for example, one condition that we're doing active clinical trials on, and we are showing actual clinical outcomes, which is COPD, for example. So it's a respiratory condition. I mean, it's a chronic obstructive pulmonary disease. There are 16 million patients recognized as such.
16 or 60? Okay.
No, 16 million recognized as such. There's a lot of talk in the industry about the undiagnosed, but diagnosed there are 16. So you have 16 million people you can get on an RPM program. All of them should be. Yeah.
Sure. So $150 a month, that's $2.4 million a month, or about $30 million run rate for you, getting 100% penetration of this market. That's actually not that big, right? For what you guys are building. That's very small.
Actually, I don't know how you got to it, but if you have
16 million. Sorry. You're right. I missed a bunch of zeros there. 16 million. So how do you, the test you're running right now on the 50 devices, you're targeting the US market exclusively?
Yes, right now exclusively. Yeah.
Okay, got it. Sorry, that math is obviously much bigger, right? So 16 million patients at $150 a month is like 2.4 billion a month, right?
The reason exactly
per month. The reason I bring this up, right, is that's almost $30 billion per year, right? Which effectively is going to come out of my pocket, right? It's me paying, it's the U.S. citizens paying into Medicare, Medicaid, or the U.S. government printing more money to cover these expenses.
Actually saving a lot of money, and I will explain. So an average COPD patient, which is diagnosed as such, is having an average incident of hospitalization at least once a year. And this hospitalization is costing $12,000. The reason why we are enrolling them on RPM programs is because we are showing data that we can raise a flag, an alarm to the clinician taking care of them 7 to 8 days before such hospitalization event. And with simple intervention of antibiotics or steroids, you can prevent the whole hospitalization incident. So it's an economically money-saving.
So how many hospitalizations are there right now in the U.S. from COPD patients exclusively?
Every year, 16 million, because it's on average once a year. Yeah.
So every single person in the U.S. with COPD goes to the hospital at least once per year?
On average. So some more, some less. That's the average rate. Yeah.
I see. Interesting.
Yeah. So
what you're arguing though is that with your early indicators, right, via the veins in the skin and the early things 7 days early, you're basically saying you're not going to replace all 16 million hospitals.
No, we are not, and it's going to be very irresponsible of me right now to say exactly how many we are. But what we are showing, and I'm going to be very accurate with you, Nathan. What we are showing is that we are raising an accurate alarm flag 7 to 8 days before. In very high rates, like 95%. Okay, 95% of the hospitalization cases of the clinical trials of the sample we sampled, we are showing a very obvious deviation of a score combined out of oxygen sat, heart rate, and respiration rate out of norm, and we know that there is an effective intervention. So we believe and that's what we are pitching, that there's going to be a substantial economical benefit to this RPM program.
Why does it have to be your IoT device? I mean, listen, I use Whoop, and I look at resting heart rate, I look at respiration, I look at the exact same things you're talking about. And I could tell when I was getting COVID because my resting heart rate was jumping through the roof. It was very obvious. They put a little warning in the app that said, you probably have COVID. And sure enough, I did. Why can't somebody else do this for much cheaper?
Okay. So it's actually a very good question. So you are asking me to compare ourselves to wearables because wearables are everywhere. So number one problem with COPD patients and with other chronic patients, especially elderly, is compliance. Everything that requires them to take action, which is charging, putting it back on, tolerating it even, pairing it with the phone, is going to lead to low compliance. So there are a lot of attempts to use wearables with them. It just doesn't work.
Isn't it harder to convince all of them to install this thing on the desk next to their bed and make sure their skin is exposed for at least 5 minutes every day so your thing can do the reading?
No. What you're describing is not passive. If I would have pitched that would have been bad. What I'm claiming is that they don't need to do anything. It just happens. I mean, there is.
They have to install the thing. They have to install the thing in their house.
No. You need to install the thing, but
so that is something, right?
Routine,
just like you have to buy a wearable and put it on your wrist.
Fair enough. No. But once. And for years, you don't need to do anything. That's once. You don't need to expose. I mean, what you describe, you need to expose your skin. Absolutely not. I reject it completely. You need to manage yourself naturally. There was, in the clinical trials we've done, there was no single night we didn't collect quality data over the night in enough samples to filter
out. How close
outliers.
Do they have to sleep to your device? 5 feet, 2 feet, 10 feet?
5 to 6 feet, not 10 feet. Up to 6 feet, it's enough.
So as long as their body is sleeping within 6 feet of your device can get the readings they need.
Right on.
Yeah, I see. Interesting. Okay, give me the backstory here. When did you launch the business?
So we launched the business in 2018.
2018, and have you guys bootstrapped or raised?
We bootstrapped for a year, and then we raised a seed round of 9 million in 2 tranches in 2019 and 2020. Okay.
9 million, and then
it's a deep tech. That's why it takes. We are going to raise more for conduct in early 2022 to.
Okay, but 9 million total to date.
9 million total to date. Yes.
How much have you already burned through?
I mean, we're not sharing that. Yeah, I'm sorry for that. We're not sharing that. I can tell you that we are 13 people. Okay, we're not a big company. All of them, a part of me, are researchers and engineers.
How many are full-time on the team?
All of them.
How many?
13. Yeah.
13. Okay, so there's 13 on the team. How many are engineers?
So half of them are researchers, half of them engineers, and I'm the only one who's doing all the rest.
I see. And are you the only founder? Do you own 100%?
No. We're 2 co-founders. So my co-founder was working with me in Apple, and he's the brains behind the technology. He's a PhD in computer vision. He's one of the brightest minds in Israel in computer vision. Yeah.
Okay, you guys just split it 50-50, or he gets more because he's smarter?
No, well, you should bet, but I'm lucky, so we're 50-50.
Yeah. All right, you guys split it 50-50. Obviously, you do a seed, you take some dilution. Most folks are raising seeds now, and they're selling, call it 10 to 20% of the business. Were you sort of in that average?
We were diluted by the 2 rounds that we entered this is, of course, naturally. Yeah, but we're very proud of those partners. Yeah.
My point is, though, most people are, when you raise that money, you're giving up and selling 10 to 20% of the business, correct?
Yeah. Well, 10 is in the low side. Yeah.
Yeah. But you didn't give up more than 20% for 9 million, did you?
Yeah, I'm not sharing that. Sorry for that. Yeah.
Okay. Well, I mean, that would be a yes. Why? No, I mean,
that's my internal business. It shouldn't be too interesting. Yeah.
Well, what do you mean? It's extremely interesting. The more you're diluted, the less control you have. It's the number one thing that matters when you're trying to build a business is control, so you can execute your vision. It's the most important thing any founder can be thinking about when you're launching your business. So I totally disagree that it's not important.
And so let's agree to disagree. I've done it in the past.
With what company?
No, with PrimeSense. We had a beautiful company. We entered VCs.
You were VP of business development, correct?
Yeah.
Okay,
I was not the founder. Fair enough.
You're not the founder, so it's completely different.
But I know how it worked. So if there is one thing that I will push very hard on, is that there is no one formula to build the startups. Okay, they're all different. So the story,
which is exactly why I'm asking. Right? That's exactly why I'm asking. Why are you okay taking 20-30% dilution so early? Tell me more about the quality of the money. Where was it coming from? Why did you need these partners?
Okay, the quality of the money I will tell you. So it's coming from a very reputable Israeli VC called 10D. Okay, 10D, you can look them up. I mean, it was founded by one of the most reputable venture capitalists in Israel, a veteran. And the other fund is called Supermoon Capital, which is out of Silicon Valley. There are other private investors, but I will just focus on those two because they are the most active investors, and I'm working with them almost on a daily basis.
Mm-hmm. Very cool. All right. Did you learn anything about the equity? How equity was managed at PrimeSense? Mistakes that you want to make sure you don't do here in your current business.
Your point that my job was very different than FSC is than a founder. I'm learning every day how different this was. So I had some exposure, but not complete exposure. I was not going through what the founders went through. I was mostly on the operational side. So that's a fair point. Yeah.
Yep. Look, that company raised 36 million, well, almost $40 million, right? And so that 20 million Series B, if they were raising at minimum 10x, it was probably higher than that. That's almost a 300 million valuation. But
you are talking about PrimeSense, right?
PrimeSense, correct? Yeah. And then they go out at 2008, right? Then you go out and sell to Apple for 360 million. That's basically at the valuation that it was 4 years prior to the exit, right? So you just lose optionality. But I get it. You're building a company that requires a lot of capital investment up front. There's an IoT play,
absolutely.
There's tech.
Yes.
So I get it.
Yes.
Okay, very cool.
FDA and so on.
Yeah. 13 on the team. So when do you guys think you'll have your first paying customer?
Early 2023.
2023?
Yes.
Wow.
Yeah.
Why not next year?
No. Because you need, in order to in order to make business reimbursement-based business, not out-of-pocket business, reimbursement-based business in healthcare in the US, you need to have FDA. In order to have FDA, you need to complete clinical trials, you need to do submission, and you need to wait for clearance. So, yeah, I'm a very realistic person. I can say 2022, but I can guarantee 2023.
Mm-hmm. What are you looking to raise more right now?
Yeah, we have a decent runway ahead of us. But we are keeping our options open. If there is going to be a very, very smart money in good terms, why not?
Mm-hmm. What would you consider really smart money?
Money that comes from the domain, that open doors, that
name an investor that you'd consider.
No, I'm not going to name.
Name an investor who'd be a great partner for you, or you would kill to have them involved. Why is that a hard question, Adi?
No, because what would the other investor say? I'm not naming names. Yeah, because what if I don't get them? Did I get my second best? So that's why I have my own lists, and that's a private information. Yeah.
Who would be very strategic for Claire?
I would describe them and not name them. Okay. Reputable VCs that are operating in digital health and medical, or venture arms of the leading medical devices companies. Yeah.
Who is a leading medical device company? Ignore who you want. I just don't know, right? Who is these answers aren't helpful to my audience who doesn't know your space, right? So who is a top medical device company?
Okay, so that's easier for me. Okay, because that's clear. If you look at companies like Medtronic, Masimo, ResMed, Philips, those are beautiful names to have involved in my company.
Now, see, was that so hard? Was that really that difficult? Was that difficult?
No, it's fine. Yeah, but I'm not going to do. Sorry for that, Nathan.
Yeah. No, it was so simple, right? That's so helpful. Yeah. Thank you for answering. Yeah. All right, let's wrap up with the famous five. Number one, favorite book.
Wow, favorite book. Wow, I didn't prepare for that. So it's actually The Corrections by Jonathan Franzen. Yeah.
Number two, is there a CEO you're following or studying?
Actually, it's Philips. I know him for many years. I worked under him directly. Frans van Houten. Yeah. When I lived in the Netherlands. Yeah.
Number three, what's your favorite online tool for building Claire? Sorry.
My mentors.
No, your favorite online tool.
Online tool. I don't know. We're working with Monday, if that's relevant.
Monday.
I'm not too in love with it. Yeah. It's just a tool. Yeah.
You can't say that. Roy is another, Israeli engineer. You've got to say you love it.
No. I'm working with them, but I'm not in love with any online tool. Yeah.
Fair enough. Number four, how many hours of sleep do you get every night?
Oh my God, that's a bad one. Much too little. So I would say, to give you a direct answer, I don't know, 4 or 5.
4 or 5. And what's your situation? Married, single, kids?
Married with 2 kids.
Okay. And how old are you?
50. That's the toughest one.
50?
50, yeah.
All right. Last question. Something you wish you knew when you were 20.
Something I wish I knew when I was 20. Wow. I was asked in my 50th birthday if I have any regrets or if I would have done things differently, and I answered no, which is probably a lie, but I'm happy to believe in this lie. So I will.
This is not a regret question, Adi.
Yeah.
It's for other people who are 20 who are listening. That would love to learn from you, right? So something you wish you knew when you were 20.
I mean, do relocations, explore other cultures as early on. I did not enough of it, and and I should have done it. Yeah.
Claire Labs, guys, they've invented a way to basically install, think of it like a light or a lamp next to your bed for COPD patients to understand, again, early warning signals to try and prevent hospital visits, save taxpayers a lot of money. They're targeting the US market. 50 devices shipped today in clinical trials. They raised $9 million to get this thing to market, hoping to get their first paying customers by 2023. 13 folks on the team. We will see what happens. Adi, thank you for taking us to the top.
Thank you. That was super fun. I appreciate it.
One more thing before you go. We have a brand new show every Thursday at 1 p.m. Central. It's called Shark Tank for SaaS. We call it Deal or Bust. One founder comes on, 3 hungry buyers. They try and do a deal live, and the founder shares back-end dashboards, their expenses, their revenue, ARPU, CAC, LTV, you name it, they share it. And the buyers try and make a deal live. It is fun to watch every Thursday, 1 p.m. Central. Additionally, remember, these recorded founder interviews go live. We release them here on YouTube every day at 2 p.m. Central. To make sure you don't miss any of that, make sure you click the subscribe button below here on YouTube, the big red button, and then click the little bell notification to make sure you get notifications when we do go live. I wouldn't want you to miss breaking news in the SaaS world, whether it's an acquisition, a big fundraise, a big sale, a big profitability statement, or something else. I don't want you to miss it. Additionally, if you want to take this conversation deeper and further, we have by far the largest private Slack community for B2B SaaS founders. You want to get in there. We've probably talked about your tool if you're running a company or your firm if you're investing. You can go in there and quickly search and see what people are saying. Sign up for that at nathanlatka.com/Slack. In the meantime, I'm hanging out with you here on YouTube. I'll be in the comments for the next 30 minutes. Feel free to let me know what you thought about this episode. And if you enjoyed it, click the thumbs up. We get a lot of haters that are mad at how aggressive I am on these shows, but I do it so that we can all learn. We have to counter those people. We got to push them away. Click the thumbs up below to counter them and know that I appreciate your guys' support. All right, I'll be in the comments. See ya.